Hi, Peace Psych, and happy Monday. Hopefully, you're watching this on Monday so you get the last piece of information you need for your project that's due on Wednesday. So, our topic focus for today is going to be the biomedical therapies. And if you remember back to the very first lesson for this unit, we talked about how all of the other perspectives fall under this broad category of psychotherapies, and then biomedical therapies kind of stand on their own. So I think you'll see that. I don't think there'll be any big surprises in terms of what is considered, there we go, a biomedical therapy just from the name. So here we go. Our essential question is still, how are psychological disorders treated? Our learning targets: I can describe the central characteristics of psychotherapeutic intervention. I can describe prevention strategies that build resilience and promote competence. And then finally, I can summarize the effectiveness of specific treatments used to address specific problems from my biological perspective. And that'll be really where we spend most of the time today. So we're going to start off with drug therapy. So looking at different medications to treat various psychological disorders. So first, just in general, these drug therapies are called psychopharmacology. And this area of study looks at the effects of drugs on the mind and behavior. This slide is a great review of our research unit, looking at how drugs are initially tested. They're generally tested using a double-blind procedure. Hopefully you remember what that is. I'm actually going to add a question here for you to test that out. So I want you to tell me, what does this mean, and why is that important when determining the effectiveness of a drug? So I'm going to have you type that now, and don't look it up, don't Google it before you type it into the question here. So here you go. Okay, so hopefully in your explanation, you said something like people are divided into two groups, the people that are involved in the trial. So someone would be randomly assigned, meaning literally at random, put into one of two groups, either an experimental group or a control group. And the experimental group people get the actual medication, where the control group people get a placebo or something that is like a sugar pill, not the actual medication. And what makes it double blind is that the people in those two groups, the participants, don't know what group they're in. And likewise, the person administering the medication doesn't know what group they're in. Okay. And that's important so that we have some means of comparison to see if this medication is actually effective. If people in the placebo group have similar results to those in the experimental group, you have to think about, what does that mean for that medication? Does it actually work in the way that the researchers hoped it would work? So the first category of drugs or medications that we're going to look at are called the antipsychotic drugs. And what you should notice in here is this word psychosis. If you remember, psychosis is a break from reality. So this would be used with people who have things like schizophrenia, sometimes some types of things like bipolar disorder, but schizophrenia will be the main thing that we look at here. So what they are meant to do, when I talked about schizophrenia, I said that there is no cure. Okay, there is still no cure for schizophrenia. But what these antipsychotic medications are meant to do is to relieve and reduce the symptoms of. So for example, meant to lessen positive symptoms like hallucinations, like those delusions that people so often experience. And the way that they work, most of them are antagonists. So another great review word here, back to our bio unit. So antagonists are those drugs that work to, remember, they kind of act similar to neurotransmitters if they're agonists. But if they're antagonists, they actually block the work of those neurotransmitters. So these are similar enough to the molecules of dopamine, where they occupy its receptor sites and block its activity. So notice that they're working on dopamine. Just a little reminder I put here. One theory about the cause of schizophrenia is an overproduction of dopamine. So it's going to keep the body from producing too much of that dopamine. So those dopamine neurotransmitters can't bind to the neighboring receptors on those neighboring neurons. So they can't act in that way, and thus lessening the symptoms that that person experiences. There are several types of antipsychotic drugs. If this was going to be on our AP exam, you would be expected to know these different types, but since we're not, I still want you to be aware of them. So there's a first generation antipsychotic. Notice they both worked on dopamine receptors, just different types. So the first targeted what were called as D2 dopamine receptors. One of the most popular medications was called Thorazine. Thorazine worked well, but it had a pretty significant side effect called tardive dyskinesia, which is basically involuntary movements of the limbs and the facial muscles. So a person, while some of those hallucinations or delusions, those positive symptoms might have been controlled, tardive dyskinesia was a very real side effect of those. There is a newer generation, also works on dopamine receptors, but this works on the D1 receptors. Some of the brand names you may have heard are clozapine, Risperdal, and Zyprexa. They have fewer side effects in terms of major ones like tardive dyskinesia, but they also increase someone's risk of obesity and diabetes. The next type are anti-anxiety medications. They're used to control anxiety and agitation. So you might imagine they're used to help with things like anxiety disorders, panic disorder, PTSD, and OCD. The interesting thing about anti-anxiety drugs, you may have heard of things like Xanax, is one that you've probably heard the name, or Ativan. Um, they're highly addictive, and they aren't necessarily the drug of choice to treat those anxiety disorders for the long term. So, for example, if someone has, say, generalized anxiety disorder, we wouldn't use Xanax as an everyday type medication. It's more of when the person's anxiety becomes so overwhelming, then they might take a Xanax or an Ativan. Or if they're having a panic attack, they might take one of those things. Or to help them deal with exposure therapy and to help lessen that anxiety so the person can even go through with those exposure therapies. But what we'll see is anxiety disorders are actually more often treated with what are known traditionally as antidepressants instead. So some of this I've already said. So some of the criticism is they might reduce those symptoms, kind of those physiological feelings of anxiety, but they don't resolve the underlying issue, particularly if it's something like obsessive compulsive disorder or PTSD. They don't resolve what's causing the person to have that anxiety. And two, by using a medication, that can create a learned response where the immediate relief reinforces a person's tendency to take drugs when anxious. So it acts as a negative reinforcer. It takes away that negative thing. So the next time the person starts feeling anxious, rather than using a technique like mindfulness or breathing techniques to help calm themselves down, or a cognitive behavioral technique, they might learn, well, I can just take this medication and then I won't feel this way anymore. So it makes makes them more likely to become addicted to that medication. And that's not to say that medications, when used appropriately, aren't good. If it's appropriate to the situation and the person needs that to be able to manage their symptoms, by all means, under the care of a medical professional. But it's also something that we need to be aware of and that clinicians and psychiatrists are also aware of. Some of the withdrawal symptoms when someone stops taking these medications include increased anxiety. And that's why they need to be used with caution and why it can be so alarming if someone is using them, especially not under the care of a medical professional. Antidepressant drugs, we're going to spend a little bit more time on these. It's a great review of our neuron anatomy and physiology as well. So, antidepressant drugs are used to treat not only depression, as the name implies, but also things like anxiety disorders, obsessive compulsive disorder, PTSD. So, they're used fairly broadly in terms of different diagnoses we've discussed. What they're known best for is lifting up a person from a state of depression. Some of the common names you may have heard of are things like Prozac, Zoloft, Paxil, and all of these fall under a category of drugs called SSRIs, or selective serotonin reuptake inhibitors. And I know I talked about this just as kind of a preview when we were back in our bio unit first semester, but a little refresher for you. One, serotonin, you should recognize that as a neurotransmitter whose one of its primary functions is related to mood. Two, you should notice this word reuptake. If you remember, after our action potential, when those neurotransmitters are spilled into the synapse, that any leftover neurotransmitters that don't bind are taken back into the sending neuron. Okay. And then finally is this word inhibitor, meaning it's going to prevent reuptake. So how does it work? And then I'm going to show you a diagram as well. Is it increases, they are mostly agonists. It increases the availability of norepinephrine or serotonin, depending on what particular drug. And these neurotransmitters elevate arousal, hence the norepinephrine, and mood, that's serotonin, that appear scarce during depression. And when we look at antidepressant drugs, they are most often used in combination with some other type of psychotherapy. So, very rarely will you see someone who has depression who is only given a medication. Most likely, it's some sort of biomedical therapy along with some sort of psychotherapy like cognitive behavioral therapy or CBT. So, some studies suggest that the best method to treat things like major depressive disorder is using combinations. So, this, remember, is an eclectic approach where we're coming from a top down approach using something like cognitive behavioral therapy and a bottom up approach with something like medication. So, review here, this is a great review of neural transmission. So, we have here, this is our axon terminal. Hopefully, you remember that's the end of our neuron. Up here, where you can see my cursor, hopefully, this is our axon. So, that electrical impulse has sent down into the axon terminal. If you remember, these bigger circles, the bigger, like bluish circles, are our vesicles. And these little yellow circles inside, those are our neurotransmitters, in this case, serotonin. So when that action potential reaches our axon terminal, those vesicles bind to this membrane and they release that serotonin into the synapse. Okay. So, and those serotonin move across the synapse to receptors on this neighboring, on the dendrites of this neighboring or receiving neuron. Okay. And generally what happens is any excess serotonin is reabsorbed through this process called reuptake. It's repackaged, sometimes it's just absorbed by that sending neuron. So how these SSRIs work is they partially block reuptake. So you notice here, they're not necessarily working down on this receiving neuron, they're actually preventing reuptake from happening. So you can think of them as like blocking the door. And what that does is it leaves more serotonin in the synapse. Otherwise, all that excess that didn't bind would have been taken back up into that sending neuron. So what I'm going to have you do is explain how antidepressants, specifically the type known as SSRIs, I'm going to have you explain in your own words how they work. And I would love for you to use as much of this terminology in terms of the different parts of the neuron and in the axon terminals. Basically, think of this diagram. Explaining all of this as best you can, mostly because this is a great bio review as well. So I'm going to give you a moment. You're going to explain, and then we will move on. Okay. The next type of medication we're going to look at are known as mood stabilizing medications. And what that should tell you, the idea of mood stabilizing, is that they're used primarily to treat things like bipolar disorder. And the most commonly used mood stabilizer is lithium, which is actually a salt. And this is one of those medications that we're not sure exactly how it works. But what we know is that it does help to prevent or ease manic episodes, which is one of the primary concerns with bipolar disorder. And it somewhat also helps to lift depression. And what we found is that people with bipolar disorder who take lithium, their suicide rate is lower than those that don't take it. But again, we're not exactly sure how it acts on the brain to help ease those manic episodes. We just know that it's pretty effective at doing so. So that wraps up our medication section, our drugs. What we're going to look at next are various types of brain stimulation that is used also as biomedical treatments. So the first biomedical treatment in terms of brain stimulation that we're going to look at is something called, or abbreviated as, ECT, or electroconvulsive therapy. And this is one of those treatments that probably has the most negative stereotypes surrounding it. Primarily when it's showed in the media, in movies or TV, it's shown as extremely inhumane, as you hear it called shock therapy, and it can make it seem really scary. But in fact, ECT is one of the most effective treatments that can be used with someone who has otherwise treatment-resistant depression, meaning that person has gone through various different types of psychotherapies, has been on various different antidepressants, and yet their mood is still extremely low, often to the point of constant suicidal thoughts. So the way that ECT works is, first the person is anesthetized, so they are under anesthesia. They are not awake for this process. And as you can see in the diagram here, it's done in a hospital, a medical office type setting, where they have electrodes that are placed on their heads. All their vital signs are monitored throughout. So they monitor their heart rate through ECG, their blood oxygen levels, their blood pressure, etc. They're given a muscle relaxant. And really what happens is this brief electrical signal is passed into the brain via those electrodes. And what they really do is instigate a seizure. Again, very controlled. It doesn't harm the person that is having this done. But what they found is that when doing this, and often the treatment will be done multiple times, sometimes a few days to a week apart, depending on the person. And what this does is almost like resets the brain. And we're not sure exactly why it works, but it tends to be pretty effective, very effective for a lot of people. So I'm going to show you this video that explains it a little bit more and the benefits, and then we will continue. Oh, shoot. I hate when I do that. Let me go back. Okay, here you go.
Electric jelly on the temples, strap on the electrodes, insert a mouth gag, then a jolt of electric current. It's a rapid response therapy that's been around a while. It's called ECT, electroconvulsive therapy, better known as shock treatment. Introduced to the U.S. around the same time as lobotomies back in the 1940s, ECT still stirs strong emotions as a brutally archaic torture rather than a modern, useful treatment. But ECT is as common as ever, and there's only one reason why. It works.
I was under the bridge for a few days with the crackheads and the alcoholics. It was kind of like I was suicide by, it was just going to be a slow death. I just wanted to sleep it away.
A successful serial entrepreneur, Gary Halliday lost it all and found himself at Western Psychiatric in Pittsburgh.
They had given me an antidepressant and I wasn't responding. Being in that severe of a depression for a year or so, they felt I was medication resistant at that point.
Out of options, doctors recommended that he participate in a clinical study.
And the study was ECT plus medication for 8 months.
It sounded terrifying and barbaric, but doctors insisted ECT could help.
I was desperate at that time. I was totally desperate. I had nothing, nowhere for me to go, physically or emotionally. And, it worked.
Usually people are referred to me because everything else has not worked.
During her time as the chair of psychiatric and behavioral sciences at Duke University, Sarah Lisenby has advanced our understanding of just how effective ECT can be.
ECT induces remission in upwards of 80% of people. It's very rapidly effective, and in particular, people with bipolar disorder with severe depression respond extremely rapidly to ECT.
ECT and DBS both rely on electricity. Electric current applied to the brain changes the way neurons connect to one another and even stimulates the growth of new neurons.
The brain is capable of rewiring itself quickly and in a profound way. Every time we learn a language or we learn to play the violin, we're changing the way the brain is wired up.
Okay, so hopefully you see that ECT, although it sounds scary, despite how it's been depicted on TV, can be a very effective method or treatment for people who have otherwise been treatment resistant. Another type is called repetitive transcranial magnetic therapy. And this is done through the application of repeated pulses of magnetic energy to the brain. Think super strong magnets, as you see in this diagram here. It's used to either stimulate or suppress brain activity. And one of the bonuses is it has less side effects than ECT. One of the things I didn't say, one of the main side effects of ECT is some short-term memory loss in particular. But its effects or its results aren't as strong as what we see with ECT. So it's a trade-off there, and that would be something that a clinician would weigh their options of side effects versus effectiveness for that individual patient. Another one is deep brain stimulation. That would be kind of what you saw in that diagram at the end of the video. It stimulates a neural hub that bridges the frontal lobe and the limbic system. And what they found was that, so it's literally like a probe that's embedded into the brain, is that in one study of 20 patients, so a fairly small sample, 12 experienced relief from depression, which was sustained for quite a long time, for 3 to 6 years at follow-up. It's just not done as often as what we see with the other two. The final type of biomedical therapy that we'll look at are psychosurgeries. So a psychosurgery is a surgery that either removes or destroys brain tissue in an effort to change behavior. And the most common type that you may have heard of is a lobotomy. And lobotomy is a procedure that cuts the nerves connecting the frontal lobes to the emotional controlling center of the inner brain, like to the limbic system. Today, it's a lot more sophisticated than what were known, particularly in the 50s and 60s, as ice pick lobotomies. You're actually going to be hearing from someone who had that done when you do the other assignment for today. They are more sophisticated than that today. They're only done as a very last resort and focus more on small nerve clusters compared to how they were previously done. The last type of therapy is the type that maybe isn't so much biomedical, but is still important nonetheless. And these are therapeutic lifestyle changes. And what this is focusing on is the mind body interaction, understanding that we're a biopsychosocial integrated system. And you've seen this as a theme throughout the entire course, that we can't examine just someone's biology, just their psychology, just what's going on in their social environment when we're trying to figure out someone's behavior, but instead know that each affects the other. So, knowing that, we know that one, humans are built for physical activity and social engagement. So, how can we use those things to our advantage to treat someone who's experiencing a mental illness? So, there's been a lot of research looking at things like a big, huge one is aerobic exercise. Exercising, they found, has been as effective in treating mild to moderate depression as any antidepressant. Okay, that's huge. And that is not to say, please don't take this as me saying, don't take medications if you or someone you know requires it. Medication can be a wonderful thing that can be very helpful. But it's also understanding that there are things like exercise that someone can do that can be as effective or that can aid in that person's recovery. Other things that we know are really important. I talked a lot about sleep when we were in that unit and how sleep is so incredibly important, not only for our physical health, but our mental health. Things like light exposure. I don't know about you all, but when it rains a lot, especially being in Southern California, I can feel my mood start to slip. And that's not saying to the point of necessarily being diagnosed with something, but there's definitely a difference in my own demeanor when it's cloudy versus when it's sunny. So, for example, the last few days at the end of last week, we had bright sunny days, and even given all of our circumstances, I was doing okay. This next week coming up, with seeing how much rain is in the forecast, I worry a little bit about my own mood and our circumstances. So I know I'm going to have to make a point to do things like get exercise inside my house or do something, so I don't see that my mood lower. Social connections are also extremely important. Anti-rumination, meaning enhancing positive thinking. Think of it almost like cognitive therapy on yourself. How can you change that mindset? And nutritional supplements as well, looking at things like vitamin D too. And what they found was when people took all of those things into account and were taking actions with each of them, that 77% of people who participated in the study, looking at the interaction of all of those things, had less depressive symptoms. So, what you should take from this is that biopsychosocial is really important. That if we're really going to address treating someone with mental illness, we need to look at them not just from any one perspective or any one angle, but really we need to be looking at the person as a whole and all of these biological elements, all of the psychological elements, and also all of the social elements, both on looking at the cause of their mental illness as well as how to treat it. So that is the end of the notes. I do have just a couple, I think it's 2 or 3 multiple choice, just practice questions for you. So here you go. So most antipsychotic drugs mimic a certain neurotransmitter by blocking activity at the receptor sites. These drugs affect which one of the following neurotransmitters? So go ahead and answer. You should have chosen D, dopamine. Next. In an effort to help a child overcome a fear of dogs, a therapist pairs a trigger stimulus, something associated with dogs, with a new stimulus that causes a response that is incompatible with fear, for example, an appealing snack or toy. Which clinical orientation is this therapist using? I'll go ahead and answer. The correct answer is B, behavioral. And that is all I have for you. So your other assignment for today is going to be the podcast about Howard Dolly, who had a lobotomy. I highly recommend it. I think you guys will enjoy listening to someone who experienced that themselves. And he's very open with his experience. And after that, Tuesday, you have a work day to finish up your project, and then your project will be due on Wednesday. I hope you have a great rest of your day.